Hi everybody, my name is Jodi Lyons and welcome to Your Need to Know. I'm here once again with Dr. William Mansbach of the BCAT. Good to see you.
Good to see you, Jodi.
So this is a continuation of a show we had done earlier because we've gotten so many requests for more information when we talked about the behavioral and psychological symptoms of dementia. So I'm glad you're back.
Thank you. Nice to be here again.
I'm hoping that this time we can talk a little bit about practical implications of behaviors and ways that caregivers can help alleviate some of those behaviors. So I guess the first thing to do is define quickly, what are we talking about? What is a BPSD?
These are the behavioral and psychological symptoms of dementia, as you alluded to. And as we talked a little bit before, we tend to think about them as occurring in sort of three different categories, right? Three different bins or baskets or buckets in some ways. So for those people who are watching who take care of a person who has dementia, either a loved one or in a professional capacity, you'll be familiar with these. So there are those behaviors that we think of as behavioral: combativeness, verbal aggression, wandering, disrobing, things of that sort. Behavioral discontrol really implying that these are outside of a person's conscious ability to control in some ways. So that's sort of one category. The second one are mood issues, usually depression or apathy or anxiety, sometimes referred to as emotional agitation. The third category being perceptual distortions. These tend to be delusions or fixed thoughts that are not really true, or hallucinations. For people who have dementia, they tend to be more on the visual world rather than in the auditory world.
So they're seeing something and not necessarily hearing it. So seeing something that's not there?
Exactly so.
Okay.
Right, exactly so. And these seem to be, they evolve out of, caused by changes in the brain, very different than what you would expect from a traditional psychiatric disorder like schizophrenia or bipolar mania in some cases.
Well, that makes a lot of sense. So in my world, these behaviors seem to be one of the biggest causes of caregiver burnout. That the caregivers don't know how to handle the behaviors. Sometimes they're scary. So can we talk a little bit about whether or not the behavior is normal for somebody with dementia and that we can deal with it versus this is a crisis and we need something different? How do we know if it's normal?
Okay, so I think you're talking about how do we manage expectations? How does
That's a good way to put it.
How does a caregiver make sense of what she, and I say she because, well, not all caregivers are female, the majority are, right. What is she really seeing? Just in terms of what is normal and what isn't, I think what we could say is what is common.
Okay, that's a better way to put it.
8 out of every 10 individuals who have dementia will show or demonstrate at some point one of these symptoms in these three categories that we've talked about. Unfortunately, they tend to go together. That is, people who have dementia, who become behaviorally discontrolled, let's say combative, usually around caregiving issues. Or personal care, bathing, dressing, feeding, things of that sort. So these behaviors occur, but also you have these perceptual distortions that happen at the same time, so that they go in tandem in some ways. So 80% of people who have dementia are going to demonstrate these symptoms. Often they occur in sort of the middle stages of dementia. Usually they're not very frequently occurring in the initial stages, and toward the end of a progressive illness like dementia, the brain is beginning, those neurons are turning off, and so you begin to see less of these behaviors often than you do in that sort of middle band. So it is common, or if you will, normal to see this.
Okay, so now we could talk about how to deal with it. So one of the most common things I hear is, everybody stole my stuff. That was actually second only to drug cartels being run out of facilities because that happened to be the delusion the person had. But there seems to be a paranoia that happens a lot. So let's say you're a caregiver either at home or you're the family member and your loved one's in a nursing home or something like that. How do you respond to the absolute certainty that the person with dementia has that somebody stole their stuff.
Right, so it's a fixed belief, right? Fixed belief. So trying to convince a loved one or the person with dementia that they are wrong, that it didn't happen, is probably going to result in more agitation rather than less.
Right.
We often recommend that we use more of a reality or validity approach, which is change the channel, change the subject, but don't argue. Because arguing tends to escalate. And in fact, this happens for people who don't have dementia.
Well, exactly.
It certainly happens for people who do. So rather than saying, no, your purse wasn't stolen, it may be, well, let's see if we can find your purse. So this is changing the dynamic, changing the conversation. We think about it as changing the channel in some ways. To put it in a proper context, though, so that people, this gets back to your idea of what's normal or what's common for people who have dementia, there's a term that we use called confabulation. Confabulation.
Right.
So
I've heard that before.
This is where these perceptual distortions really come from. So there are gaps in memory, so the brain fills those gaps in with readily available information or content. So it may make sense in a strange kind of way.
Okay. So
I
they're
can't
not
find
lying.
my purse, so someone must have taken it in some way.
Okay. So they're not lying.
Right.
They truly believe what they're saying, but their brain just filled in a gap.
The brain filled in a gap. So we call that the principle of closure, and there's an area of psychology, sensation and perception. So there's quite a lot of research that's happened since really the 1920s that have shown, and I think we talked about this once before, if I showed you very quickly a circle and just presented it in a millisecond and took it away, that circle really is a series of dots, but you might see it as a complete circle. And that's demonstrating the principle of closure. The same thing happens with confabulation. The brain is always working, always trying to solve problems. So it unfortunately fills in with content that actually is not true, not real, but certainly feels real and true to the person.
So they may actually have misplaced the purse. There may be a fact involved that is the purse is missing. The conclusion was wrong, and we can redirect by your point of let's go look for it and not arguing.
And when you find the purse, rather than saying, see, I told you, Mom,
you so, right?
It's like, oh, we found it after all.
Okay. So let's move on to something a little less benign, which is physically combative. And a lot of my clients seem to have thing about being touched. They do not want to be bathed, they do not want to be brought to the toilet, and don't try to brush their hair. What's that, and how do we deal with it?
A couple things we have to understand about the brain in a person who has dementia. So the first thing is that the ability to make sense of and deal with stimulation is a little bit different. We talk about it as a stimulus buffer, the ability to kind of absorb and make sense of the world around us that gets compromised or condensed in some ways.
Okay.
So it's complicated because if you have dementia and you're being bathed by someone and you don't recognize who that person is, you certainly don't want to be touched by them.
Right.
So in our last segment, we talked about the BCAT 3D behavioral model, right?
Yes.
And it was based on these 3Ds, defining the problem, decoding the behavioral sequence, and delivering an actual intervention. So when a person becomes combative, usually it meant that we missed a sign, we missed recognizing the tipping point, which usually happens much earlier than the actual behavioral consequence occurring in some ways. So what I would say is that there is a way of breaking down the behavioral frames where you can identify when that agitation begins to arise, and that's the point where you deliver that third D, an intervention, a change in behavior to change the dynamic. I will say this for caregivers who genuinely are struggling with a scary situation, combativeness. In most cases, it can be successfully addressed, even though in some instances it might mean changing your agenda. Maybe a bath under those particular circumstances, for example, is not a good idea, even though the caregiver may recognize hygiene is really important.
So it may not be such a big deal to just simply skip a bath, delay a bath.
Change the time when the bath takes place.
Okay. And to your point, backing up where the problem is starting is usually a lot earlier than most of us think. I was really surprised to know the problem point is not when the person being bathed hits the caregiver, but it backs up to the stages where perhaps the person being bathed didn't want to be bathed, didn't recognize the caregiver. So are there some really common techniques when you're approaching somebody with dementia and you have to go do something personal, like toileting or bathing?
Sure. We should recognize that personal care, so just as you're talking about hygiene, the activities of daily living, that sort of thing, these are intimate, physically intimate circumstances where modesty for a generation that would not readily disclose, disrobe in front of a stranger. These are real events, real things. So it is very important that we understand that what we're asking people to do when we want them to be compliant it's a pretty big ask.
Absolutely, and I think it would make a lot of people without dementia uncomfortable.
Yeah, certainly it would. So how we approach that with dignity, with respect, and with caution is very important. So I would say begin with whose agenda is it, right?
That's a very good question.
Right, because as we manage expectations, and if we say, well, let's just stop first and ask the question, what do you want to do? Why do you want to do it?
And does it have to be done right now?
Yes, so you remember when we talked about defining the program, the problem, we said that there are three aspects. What is the problem behavior, right? When does it occur, right? That was a really important aspect. And where does it occur? You might end up changing the when, for example. I had said just a few minutes ago, if bathing is really important and it has to get done, maybe when you actually do it becomes the critical question. It may be more convenient for the caregiver to do it in the afternoon, but maybe the loved one who has dementia sundowns, right? And becomes, has an even harder time making sense of the environment, right?
No, that makes a lot of sense. So it sounds like a lot of this really is caregiver managing their expectations, educating the caregivers, and then working as a team to take care of the person with dementia. And it's not always the stuff that needs to be done, it's the how and the when. That makes a lot of sense. And I notice we're getting ready to go to our break, but I am hoping there's more information about this available on your website. So am I correct? It's www.thebcat.com. And I know there's lots of information on your site, but where in particular should people look for the 3D interventions?
In the navigation on the website, in the homepage, just look for patient and family education.
Okay, perfect. Patient and family education on thebcat.com.
Right.
Terrific. And we'll be back in just a few minutes.
Saving for retirement might be easy for some folk, but for others, it might take a little more work. And for those who haven't started, there are still things you can do to catch up.
Oh, that is good news.
Like getting out from underneath past debt. And don't get wrapped up with high-interest credit cards.
Get you some eyes.
Be diversified with your investments. Don't put all your eggs in one basket. Your financial goals are not out of reach. The choice is clear. For a happy ending, choose to save.
Everyone with alcohol and drug addiction is in the same boat. With treatment, you can find solid ground. For drug and alcohol information and treatment referral for you or someone you know, call 1-800-662-HELP.
Hi, everybody, and welcome back to Your Need to Know. Dr. Mansbach, when we left for our break, we were talking about caregiver burnout and how to best handle the behaviors in people with dementia. So now I'm going to throw a really tough one at you.
Okay.
As if the disrobing and being combative weren't difficult enough. Driving. So I think many people would actually rather be hit by the person they're caring for than tell dad he can't drive anymore. So my first question for you is, how do you know when it's a problem and the person shouldn't be driving anymore?
This is indeed a tricky situation, and I would agree with you. I think families really struggle with this issue. You think about sort of the history of driving and what symbolically driving really means for most people. What is it? It's a sort of an indication of independence. And I think that there's a confusion around driving between privilege and right. People think that they have a right to drive, but actually they don't have a right. It's a privilege. And it's really based on capacity. Just as it is to learn how to drive, it's still based on capacity when it's time to stop driving. So these conversations are very difficult to have. So to try to answer your question more specifically, I would say that if there is a caregiver or adult family member who has a concern, then they probably are looking at something that is real. It may be evidence-based. Maybe dad has been nicking the car, or maybe they've heard from a neighbor that there's been a problem, or perhaps maybe there are tickets and so forth. What we suggest is that people use a safe driver questionnaire as a beginning point.
Okay.
So it's a self-assessment, but it's something that can be completed by a loved one who is concerned about a driver. I would say that there are many drivers who will readily acknowledge that it's time to stop driving, but there are many more that perhaps would have more difficulty with that. So if you go to the BCAT website, www.thebcat.com, under self-assessments, there's a free questionnaire to fill out. What's helpful about that is it's an objective way of sitting down with mom or dad or a loved one where you have issues. So there are several different items that are on there that just ask the right questions so that you can then sit down. And remember, if a person has a driver's license, they still have the right and privilege to drive until something changes that. And that's usually a conversation with mom or dad's primary care physician, a letter to the MVA to get that whole process underway.
So I sometimes get aggravated when my clients say, well, dad only drives to church, the grocery store. And I keep saying, it's not the destination, it's the process of getting there. One of my first clues is if the adult children won't let their children in the car with the parent, they probably aren't a safe driver.
Right, probably not. And it's not so much about distance, just as you pointed out. It's not even about getting lost. It's about responding to situations that are novel. If somebody on the road, or a pedestrian, or an animal runs across the road, that isn't always planned. So the ability not only physically to be able, or in a sensory way, to have appropriate reaction time, to be able to visually see what's going on or hear what's going on or so forth. But just being able to handle what we would call the executive functions that are involved is really very important. So you're right. This is not about distance or familiarity, although certainly one can get lost. It's really about handling the novel situations that can occur.
Right. And I say to people, if you can guarantee that your parent is only going to get in an accident with themselves, that's one thing. And if you want to take that risk, that's your choice. It's not your choice if they're going to hit somebody else's kid on a bicycle or my car or anything else. So I'm glad to know there is an objective test that takes the pressure away from the families and puts it on the science. So I do like that.
And if you're a caregiver out there and you're concerned about this, think about it in this way. We've all had an experience where we're driving and we're using a cell phone, right?
Yes.
So whether it's a Bluetooth or hands-free or you're actually holding the phone, you are 4 times more likely to get into an accident than someone who is not doing those
Now
things.
That's important. I want to stop you for a second. You said even if it's hands-free.
Right.
So it doesn't matter if you're holding it or not. It's that you're distracted.
It's because your attention is subtracted. So it's not what you do with your hand as much as what you do between your ears, with your head for the most part. And I think almost anyone has had this experience where they might miss a turn, or they know that they're not quite as attentive as they would be.
Right.
So if you have dementia, multiply that again by 4. And it will give you some insight into why there really are risks. This does not mean that if you have dementia, you absolutely categorically cannot drive. It does mean that if you do have dementia, the question of driving must be evaluated.
That makes a lot of sense. So that leads me to the only question I can think of that's harder than when do you take away the keys? When is it time to move, Mom? How are people supposed to know when it's no longer safe at home or in whatever caregiving environment and move somebody to the next step?
So this is a case-by-case situation,
Right.
An individual situation, but always a challenging situation. We talked about the symbolism of driving and the practical realities of driving.
Sure. I mean,
you give up driving and you need help getting your groceries, getting from
medicines and all of that. Absolutely, sure.
But giving up your home, particularly if it's a home where you've been living maybe for 50 years, maybe
Right.
you raised your children there, so much is involved in this process. In addition to just the mechanical, logistical difficulties of packing and
Right.
finding where do I go to. It's not just where do I
Right.
leave from, but where do I go to in
Sure.
some ways. But I would want families to think about this in terms of the brain and memory and so forth. Quite often, and understandably, people want to wait until the last minute before they move.
Exactly. And so my question for you is there such a thing as too late?
There is such a thing. So think about when you've moved several times in your life, I would imagine. I'm sure that those of you who are watching this program have moved many times in your life. What's involved when you move? You have to learn where's the new grocery store, where's
Right.
the gas station, where's the shopping area.
Or even
and just
simpler, where's the bathroom?
who are my neighbors?
Yes.
So the demands on your brain are actually rather significant. But if your cognition is already compromised, adjusting to a new situation may also be compromised. It is true that we advocate, at the BCAT anyway, that people consider at least moving not at the last moment, but actually when there are enough intact cognitive features that allow one to make a successful adjustment. And I'll tell you this, if you wait too long, a couple things could happen. Rather than going to assisted living, which might be less restrictive than a nursing home, you might skip over that category and go right to the nursing home. And in fact, this is sort of an irony, but moving to a more supervised situation, which isn't the most supervised situation, may actually promote and sustain independence longer than waiting and staying in this current home situation, running the risk of having a fall, some untoward event happening, going to the hospital, going from the hospital to the nursing home.
And so basically, people can be tested to see whether or not they still have the ability to make a new memory, to find the new bathroom where they're going, to make a new friend or learn the routine.
Right, so one of the advantages of the BCAT,
Right.
full BCAT test, is that not only will it help a doctor or a provider work with a family member, work with family and a person to identify where are they in the cognitive continuum, do they have dementia, do they have a pre-dementia syndrome like mild cognitive impairment or so forth. But it will also produce a memory factor score and an executive function score.
That tells
Those
us.
two factors predict function. So ultimately, it's not about can you remember
Who
X,
the
Y, or
president
Z,
is,
or who the president is.
Yeah.
But it is about, from a functional standpoint, can you manage your activities of daily living? Can you do your finances? Can you manage your grocery? Can you do your cooking? All the things that are necessary for independent
So are you
living.
safe?
Are you safe? So we do have tools for identifying people who are at risk. And so if you have questions about them, go to the doctor
That makes
or
sense.
another provider, healthcare provider, and have it evaluated.
So we have just a couple minutes here. And since we've hit really hard topics, let's talk about caregiver guilt for a moment. So I know everybody wants to stay home. And one of the things that makes me craziest is when a family member says, swear to me you'll never put your mother or father away. And then we talk about, is the person safe? Is the caregiver safe? We've talked about behaviors and driving and the things you need to do to stay safe. What advice can you give me to tell caregivers about they're not failing their loved one? How do we address the guilt?
Well, what does guilt really mean? Guilt is really based on an idea that proves to be untrue in the end, or a promise that that proves to be hasty or made without enough information.
Okay.
think the bitter realities of illnesses like Alzheimer's disease is that they really do affect more than just the person who has the disease, but they also affect the family and the communities in which that person lives or is engaged or is a member of in some ways. Guilt is a common, as you know, in your work and as someone who's so involved professionally in the care world, memory care world, is just an expectation that people are going to have, because you don't want to be the one that's going to be the heavy. You don't want to be the one that's going to have to make the hard decision.
Right.
But just like taking care of other problems in life, sometimes you have to make the right decision. Whether it's moving to assisted living or a nursing home, whether it is questions around can mom still drive in some ways, these hard questions have to be addressed. Better to feel some initial guilt, to know then that mom is in a safer environment where her well-being can be managed and preserved longer. That whole idea of, you can't make an omelet without breaking some eggshells.
Right.
It's unfortunate, but it's also true in dementia or memory care as well.
So basically what you're saying is it is okay for caregivers to make a decision and say that they can't do it anymore. They're not failing their loved one. They're not putting mom or dad away. There's a real reason for it.
And I would say this, these illnesses like Alzheimer's disease are bigger than one person. They're bigger than one family. They're bigger than one community. They require a team, and that team sometimes involves residential providers in some ways. So there comes a time, or there may come a time in the life of a person who has dementia and whoever's responsible for taking care of them, that a change in environment, just like a change in medicine or in health status or whatever the case may be, has to happen.
So to summarize what we've been talking about, there are behaviors that can be expected in somebody with dementia. There are tools to try to redirect and deal with it, but there also can come a point where it is dangerous for the caregiver and the person being cared for to not be moved to a different situation.
Exactly so.
Okay. So thank you very much. And once again, for more information for you, we can go to www.thebcat.com and look for news for families and
News for professionals.
News for professionals.
Or patient and family information.
Perfect. And for more information on Senior Sherpa, it's www.seniorsherpa.com. And of course, I have to do my weekly plug for the Alzheimer's Association, www.alz.org.
Nice to be here with you again.
Thanks.